Hello, and welcome to Talk Truth. My name is Corey Huntsberger. I've got my father, Alan Huntsberger, in the studio. We're going to start off with our foundational verse because it's important. The earth and everything in it, the world and its inhabitants, belong to the Lord, for he laid the foundation on the seas and established it on the rivers. Psalm 24, 1 and 2. Important verse, Dad, even for people that are not, say, religious or don't subscribe to a particular kind of religion. It is a foundational verse nonetheless, because it kind of gives us all, even understanding of there's a creator that created this world, and the mountains behind you, Alan, and the trees and the birds and the bears and the otters and like every little creature, every little thing. He even created humans, and here we are sharing this planet together, and that's kind of important because there's a lot of people trying to take a grab for it, right?
Right. We forget that the earth belongs to the Lord, and living in truth means recognizing that the earth and everything in it, the world and all who live in it, belong to the Lord. But the interesting thing in Psalms 33, the psalmist picks up on this same truth, and he says, "By the word of the Lord the heavens were made, and all their hosts by the breath of his mouth." So everything we see, from the mountains to the seas, came from his word. He owns it all, not us, not government, not nations. When we live with the understanding, our hearts stay humble. We are stewards, not owners, and the one who created the earth still rules it today. Living in truth means acknowledging his authority and aligning our lives with his word. And the reason why I'm bringing out living truth
I see what
is
you
our
did
books
there.
are finally arriving, and we're popping them in the mail today. So hopefully you'll get them in the next week or two.
Any chance this guy can get to pitch his book, he's going to take it. And you know what? That's honorable. Congratulations. You should do that because it is a really good book. I actually read it. It's a great little booklet, and you pulled some gold out of there. So I have no problem you taking the liberty to like squeeze that in. I noticed the minute you said living in truth, I was like, okay, this is an ad. I'm just kidding. I really appreciate everything you had to say. Hey, let's get on to our guest. We got Deanna McLeod. She is the principal and founder of Kaleidoscope Strategic, and we're going to find out a little bit about what that is. Deanna, welcome to the show. Thanks for being here.
Hi, Corey. Thanks for having me. Kaleidoscope Strategic is a medical research firm. I founded it in 2000, and it's a team of clinicians and scientists. And our normal area of research is cancer, all things cancer treatment, diagnostics, etc. But more recently, in the last 4 or 5 years, we've delved into the COVID response. And more recently, in this campaign called We Can Do Better that I'm here to talk to you about, we're looking at the two worlds have now intersected. We're noticing increases in cancer now, especially occurring over the COVID period, and we've delved in to try and figure out why that is. And we've come up with some pretty surprising realizations, and one of them is that over the COVID period, cancer care was diverted from cancer patients. Now, cancer is 6 times more deadly than COVID, and the cancer care was diverted by public health from cancer patients over to COVID units, which remained largely empty over the COVID period. And what we're seeing today is the outcomes of that policy decision. So we had siloed directed policy where public health was directing all other disciplines. And now what we're seeing is the fallout. We see drops in cancer when the services were pulled. We see a rebound when the services were reinstated. And for cancer patients, that's terrible because that means that their cancer was in their body growing and spreading while diagnostic services, screening services, and surgeries were suspended by public health. And so what I'd like to do is play you a video that summarizes a lot of what our research found. Now, there's probably other outcomes and factors that were at play. Lockdowns were bad on health. 61% of people in America basically said that they developed a bad health habit that they wanted to break. And also there was the introduction of what we call mRNA vaccines during that time frame. And those, although they were called vaccines, they were technically gene therapy that was deployed as a vaccine in order to circumvent a lot of the safety controls and regulations that are normally in place whenever you do launch a gene therapy. And so we had really wide uptake and exposure to an experimental gene therapy during that time too, which may have caused some of what we're seeing. But if you want to roll the video, it might be interesting to your viewers to kind of get just a summary, and then I can speak to some of what was in the video.
Yeah. Okay. Watch this.
Doug Ford just announced a provincial state of emergency in response to the COVID-19 outbreak. As he steps away from the podium, the first set of emergency measures are set in place. 2 weeks of lockdowns to flatten the curve. It's now January 2022. After a long 2 years of reflexive lockdowns, the measures are finally being relaxed and there is the promise of a return to normal. However, during this time, life did not just pause. For many, their lives were permanently altered. One group that was particularly hard hit were cancer patients. Our response to the COVID-19 pandemic had a devastating impact on the lives of thousands of women living with cancer. We are COVIDsense, a medical research group specializing in evidence-based medicine. We've partnered with a team of top cancer doctors and the Canadian Citizens Care Alliance to assess the impact that COVID-19 had on cancer. Our research has shown that the Canadian public health response was extremely disruptive to cancer care, producing dramatic and even deadly consequences. Looking at the Ontario Health Insurance Plan, or OHIP data, we see that billing rates for female cancers dropped dramatically in 2020, at about the same time that lockdowns began. In 2021, there was an equal and opposite rise in billing rates as lockdowns were relaxed, followed by a further rise in 2022. The same pattern was seen for breast, ovarian, and uterine cancer, and reflects the rising rates of female cancers in Ontario. What could be causing this seesaw in new cases? Lockdowns were hard on health. People reported poor eating habits, lack of sleep, excessive alcohol consumption, reduced exercise, and excessive screen time. By the end of the pandemic, over 60% of Americans said they had developed a negative habit over the lockdown period. Bad health habits aren't just annoying, they can have a major impact on health. According to a Mayo Clinic review, poor health habits such as diet and physical activity can affect cancer survivorship. The methods used to compel people to comply with public health regulations were also harmful. They kept levels of stress and anxiety high. The hyper-focus on case counts, as well as the extreme measures taken to slow the spread of the virus, left many isolated and paralyzed with fear. According to the U.S. National Cancer Institute, stress-related psychological factors can have an adverse effect on cancer incidence and survival. Stress depresses the immune system, which is the best defense against cancer. Cancer is 6 times more deadly than COVID-19. When lockdown started in March 2020, cancer screening ground to halt. Mammograms, the test used to detect breast cancer early, stopped. Rates dropped from 60,000 to 0. And cytological tests, the tests used to detect cervical cancer, went from 60,000 to 6,000. While cancer screening eventually recovered, it took until early 2022, almost 2 full years, to clear through the backlog. More than 650,000 women missed screening in 2020 alone. That's more than 32 times the number of people that Madison Square Gardens can hold at full capacity. Access to care was also deeply affected. A thorough physical exam is integral to an accurate cancer diagnosis. During lockdowns, it became next to impossible to obtain in-person care. In 2020, in-person primary care visits dropped from 750,000 in Ontario to 100,000. Care visits never quite reached pre-COVID levels, limiting access to cancer care. Compromised screening in combination with reduced access to in-person care resulted in significant delays in diagnosis for many women. This means that their cancers continue to grow and spread unchecked while they waited for their appointments. Early detection is key to cancer survival. The best outcomes occur when cancer is detected early. The the chance of survival and recovery becomes increasingly slim with the passing of time. Stage migration is when a cancer moves from an early stage to a later stage. Over the course of the pandemic, fewer women were diagnosed early when their cancers were small and easy to treat, and more were diagnosed late when their cancers had spread and cure was off the table. In addition to a lack of early detection and stage migration, the public health directives also profoundly disrupted the delivery of cancer care. The delivery of appropriate treatment, especially surgery, is critical to cancer survival. Over the COVID-19 period, over 424,000 fewer surgeries were performed in Ontario. As of March 2024, 50% of patients with aggressive cancers were waiting longer than recommended. Cancer must be diagnosed early and patients must receive appropriate care. Anything short of this can be fatal. Deaths among cancer patients increased by 4.5% in 2020, with a dramatic spike in deaths in April following the first major lockdown. There were about 1,400 excess deaths among cancer patients in 2020, and an additional 417 in 2021. These excess deaths mirrored those seen in the general population and overshadowed COVID deaths, especially among young people. Most disruptions in cancer care occurred early in the pandemic when social distancing measures were introduced and non-emergent care suspended. A review of hospital care planning in Alberta found that only a fraction of the beds reserved for COVID were actually used, raising questions as to whether the disruptions in cancer care were even warranted. Policymakers overestimated the risk of COVID and underestimated the risk of lockdowns. We can do better. For future pandemics, we need to ensure that the risks of both the virus and the public health measures are factored into decision-making. We need to ensure that policy is developed by multidisciplinary panels to ensure the needs of all patients are considered. And finally, we need to figure out why female cancers are on the rise.
Well, we appreciate that video. And I wanted to ask you this question before we get into the We Could Do Better campaign and all that. Is anyone listening to you? Do they just give you the dismissal of, well, it was an emergency, thing going on, and like, no one really knew? How have they been treating you since you're exposing this very, very important? And I love what you said. Yes, cancer is way more dangerous and will take more lives than what COVID ever did.
Well, I think that nobody ever wants to admit that they're wrong. I think that's a little bit of human nature right there.
Right.
But I think that We Can Do Better campaign is not about pointing fingers. It's about figuring out a better way. And in Ontario, and I'm sure in most provinces, there's legislation against discrimination for access to services. And so this is a blatant example of discrimination against a population of people. So in this case, female cancer patients. So cancer patients tend to be elderly, which falls under the Human Rights Code as to, no discrimination around gender. And so what we see here is cancer services were diverted to, acute care services. And that was even before the severity of COVID was well characterized. And in medicine, what we see happening is when you get this siloed decision making where each discipline is working in a vacuum, this is often what we get. We get this disparity in care. And unfortunately, this stage progression and death that's really quite concerning. And so what we're hoping to do is raise these issues and to move towards, what we understand to be better in all areas of health, which is shared clinical decision making. And I think that it's important at this point that we just learn from our mistakes and then we move forward. Not necessarily casting blame, but really understanding that just having one discipline, public health, directing a health response is just not adequate to address the needs of all patients. And so that's where we're going with this campaign. We're really hoping to move forward and chart a new path forward that's much better at balancing the needs of all patients and, just really avoiding these disparities of care moving forward.
Well, God bless you. That's such an adult, a statement of, I want my pound of flesh. You know what I mean? Like, I'm like a little child. It was unfair, unjust. People suffered. I want my pound of flesh. Now I know, as a Christian, you know what I mean? And as someone that, should love my enemies and all that, I shouldn't be that way. So I appreciate you taking the stance of, we're not here to point fingers. We're just here to point to there is a better way. I appreciate you taking that. Can you give us the details? What does this campaign entail? Like, where are you going with it? Like, what is your hope, goals, accomplishments that you're trying to get through to the people that need to listen to what you're saying?
Well, really what we're looking to do is gather the cancer community together and help them understand what happened. One of the things that's really surprising after having researched all this is most people were, we talked about siloed. Everybody was just doing what they were told in their own little silo. Trying to implement public health measures to the best of their abilities. And they had no idea the overall impact that this was having on care in general, especially cancer care. When I've shown the numbers to physicians about screening stopping or the limited access to in-person care, for instance, or the fact that surgeries were suspended 3 times, they're shocked. And what we're really hoping to do is to gather the cancer community together and to work with public health to find a way to balance decision-making moving forward, where you're actually moving from public health discerning something where they don't actually treat patients to having multiple disciplines speaking into this so that we can protect other types of patients, for instance, cancer patients. And so we're really hoping to gather the cancer community. We're hoping to bring this to the attention of the provinces and to show that there was discrimination that happens and to make sure that we've got legislation and policy in place that will prevent this for the next health crisis.
Do you have any association with Dr. William Mackis?
I don't have any association with him in the sense of know him personally. We've spoken on a number of different occasions, and he's doing some great work, finding alternative ways to treat cancer, from what I understand.
Yeah, I mean, I guess the thought comes to me, and I'm assuming that your research and your organization is more geared to the professional and maybe even the political than it is the patient. Because if you have cancer, however you got it or whatever, you want it treated. And there were people I know that were put on a waiting list during the COVID that were screaming, help us, help us, help us. And it didn't get there. When you talk about planning for the future, the problem is the money that hospitals made and the health organizations that made money on patients who had COVID or quote unquote died of COVID. They made a ton of money where they wouldn't make that kind of money, on cancer. So it really boils down to individuals who are honest and work with integrity. To me, that's the greatest concern that I have, because, even now we know that of some of the things that caused cancer, but, now we're what are we doing about it? How is this going to change? And I don't think it's going to change unless the hearts of people in the decision-making change.
I'm going to piggyback off of what Alan said. It's called health care. And I think what we're realizing, and everyone's realizing and waking up to, is there is no care. You know what I mean? It was all about the money. It was all about the just do what you're told so we don't lose our jobs. So we know there's people suffering. We've talked to hundreds of nurses, doctors, in situations like, Alan's absolutely right. It's called healthcare, and we're finding out there's no care in the healthcare system. I'm going to give it to you. What are your thoughts on that?
I absolutely agree with you that there were forces at play. For instance, economic incentives, policy incentives. Some of our research showed that, the moment that there was a pandemic health emergency declared by the World Health Organization, there were these EOCs that showed up, emergency operating centers, and they basically took control of the pandemic response and started issuing directives. There were different pieces of legislation, the HPPA here in Ontario and the, I think it was the Alberta Health Emergencies Act or something along those lines in Alberta. These pieces of legislation were triggered, and that what they did is they gave public health the position of a quarterback, where they were able to direct care across all disciplines. And I think that we're going to have to change that, because having one discipline directing care for everything, especially a discipline that doesn't actually treat patients, is really concerning. So I think what we really need to do is start to look at the legislation and then the monetary incentives that basically push people towards, a solo decision-making matrix, and move back to clinical decision-making, where we actually have people who do care about patients, clinicians, advocating for their patients and having a voice in shaping policy. This was a policy failure, and mostly because, everybody believed that public health needed to be the quarterback for a pandemic. And what we really are seeing here is that they are in no position able to care for the needs of all patients. They actually diverted care from cancer patients, which are 6 times more deadly, cancer 6 times more deadly, and diverted it to acute care wards where they were left empty. So clearly public health is not the best quarterback for this moving forward. And we're going to have to, change our legislation and change our policy frameworks and move towards what we know to be better, which is shared clinical decision-making.
Really good point.
The other thing that I'd like to add is that the colleges of, surgeons and physicians got to be changed too, because these are private organizations who are out to make money, and yet they have the power to threaten doctors to remove them from their practices and take away their credentials in order for them to practice. And that's what happened to a lot of doctors that were trying to say, hey, wait a minute, this is wrong. And this is the whole thing that, I'm just finishing up writing a book, The Supremacy of God and the Rule of Law, and return back to reality. But bottom line is, Canada started as a Christian nation. And Canada was, Dominion Day, July the 1st. Now it's Canada Day. We've slipped over the last 50 years into not even recognizing and acknowledging the Lord God Almighty. And as long as we're going to be a nation that continues to do that, we're going to continue to have the tyrants in power that are going to take charge and rule us. And whether it makes sense for better health or doesn't make sense, they really don't care. They just have their own agenda. And it really boils down to, you need people in power that recognize the supremacy of God, that they're not the final authority here, God is. And that's how our country was established. And that's, to me, what we, theoretically got to get back to. And then what you're saying and how you're building is you build on that, so we make sure that we recognize that truth.
They woke up a sleeping giant. People were asleep. They didn't know how the system worked. COVID woke everybody up. We saw through the shenanigans. We know where their priorities are now. And I believe the people are behind you, Deanna, because I believe that we want to see change. There has to be change, because we understand that they, the do no harm, the oath that they take, do no harm, meant zero, absolutely zero. And we really appreciate everything you're doing. We can do better. I agree with you 100%. I'm excited for your campaign. Where can people find more about it? How can they get in contact with you?
Well, it would be great to check out our website, which is wecandobettertogether.ca. And it has a host of information, including our social media contacts on there. It would be great if we can have your audience sharing that information with people. It's perfect to be going to their MPs to bring it up. We're going to need a little bit of political action to get people awareness up and to really, shift to a better care model for next health pandemic. I mean, the public health, it's so funny. They're their greatest champions. The public health officials are like, producing their reports and saying, we did great. COVID was so low and all this kind of stuff. And meanwhile, all the cancer patients are like, they have like advanced staged cancer and their like mortality is up. It depends. They basically look at what they want to look at. But we really need, to Alan's point, it's foolish to go against the laws of God, right?
Yeah.
We are made we're image bearers of God, and therefore each of us has dignity and worth in and of ourselves. And we are called to love one another and to care for one another, and especially the most vulnerable. So if we can't even care for our cancer patients, which are elderly and are compromised, if we want to basically allow globalist leaders who are far, far away, World Health Organization, to determine how we're going to care for our own. I think that we just can't do that. It's foolish. There's no way that they can possibly care for the ones who belong to us the way that we need to care for them. And so we just need to mobilize and do what we know to do best, which is to empower the clinicians to make health policy decisions for their patients in order to be able to protect them and to ensure that they get the best care moving forward. We need to get it out of the planners into the hands of those who care. And, that's just what this campaign is all about.
I appreciate the name of the campaign because it's very non-threatening. As they're sitting there pumping themselves up, look how amazing job we did. It's easy to come to them and say, hey guys, great job, but we can do better. We can do better. I love the name. All right. Thank you so much, Deanna. Thank you for being on the show. We appreciate you. We'll have you back for a follow-up.
Thanks so much.
And keep conversation like this on the air. We are viewer supported. You can go to our website, gotalktruth.com/donate. Many different ways to give digitally. Digital is important. I know a lot of you like to do it through the mail, but because Canada Post had 2 strikes in 1 year, I'm a little weary about it, and it does not serve little ministries like ours. You can go to our website, gotalktruth.com, click on donate. If you like to still do it through the mail, you can. You can make your gift payable to Talk Truth and send it to 246 Stewart Green, Southwest, Suite 3260, Calgary, Alberta, T3H3C8. All right, Dad, we're out of time. We'll see you guys later.
Love you.